great, thank you. So yeah, so kind of as to what Dr. Bennett alluded to, we're going to be doing a little bit of a deep dive within the 4Ms in the what matters most and sharing a little bit about how patient priorities care is one model for addressing what matters most. But before we get started, I kind of want to, oops, let me see if I got my controls. I wanted to start with this quote because I think it helps frame some of the work around this. Actually, it's a little bit older, as you'll see from the date downstairs, down below, but it really helps kind of frame that this is not something new and it's been part of geriatrics in the field of geriatrics for a long time. So as stated by Mary Tonetti, the proliferation of multi-drug regimen demands that we consider health priorities as well as the marginal benefit and health associated with the all medication when translating disease guidelines into prescribing decisions. Such an evolution from the disease-driven to a patient-driven focus requires an investment in research changes in the development of guidelines and the measurement of quality and the clinical decision making. So I think this is true, not, honestly, just only for decisions around prescriptions and prescribing, but even just any sort of intervention. As more and more technologies are developed and become available, I think it's partly, our job to step back and really put it in the context of who the whole person is and what are their goals and values before deciding, does this clinical benefit actually translate into benefit for this person? So, and why is that? So, oops, excuse me, I'm trying to move things off my screen. So part of the reason is because there's a lot of limitations to clinical guidelines. A lot of the results from trials, right, are about patient populations that don't look like many of our older adult populations that we see in clinic that have many comorbidities, oftentimes which are excluded from clinical trials, are oftentimes more complex psychosocially, and or have not just only multimorbidity, but functional impairments as well. Again, that is not included in trials. Prescribing based on survival or disease-specific outcomes is inadequate for patients who have competing, values that are about quality of life and maybe a more short-term benefits that they're interested in that aren't actually captured in many of the composite and long-term outcomes that are looked at, such as survival, morbidity as related to hospitalizations or length of stay, let alone mortality. Attention to harms of disease-based guidelines in the face of multiple coexisting conditions is lacking. And lastly, adhering to guidelines for many conditions may diminish the benefits of increased burden. So again, kind of alluding to the fact that as we are layering on guidelines, right? If a person has CKD and they have heart failure and they have diabetes, then all of a sudden you're layering on multiple different types of guidelines and associated maybe treatment regimens or algorithms that may all start to compete with each other as far as what is expected and what is the benefit, and let alone associated harms that can happen. Further, the time to treatment in the context of limited life expectancy may not be considered. And this is not even necessarily for patients who are more like hospice appropriate, within that 6 months, maybe a year lifespan, but like more even to 2 to 5 years, right? If the outcomes that are judged in a clinical trial looking, 5 to 10 years out, that person may not see that benefit if they only have maybe a few years left of life. It may be hard to identify harms of benefits of medications that expect patients to receive over many years, again, due to the lacking data from trials. Trade-offs between better short-term quality of life without treatment and long-term benefits of treatment may not be recognized. So again, kind of going back to that thought of, as a person, maybe they have some short-term milestones that are important to them. Maybe they want to improve their walking speed or their balance, but maybe they're put on a medication that has a long-term benefit that's over years worth, but may actually have side effects that hurt those things that are important to them and then keep them very functional Following multiple guidelines, as I said, increases the risk for drug-drug interactions or other drug-disease interactions. And oftentimes this is not captured well in many clinical trials. Where, we don't necessarily have ways to capture the outcomes that show adverse drug reactions or the nuances to that as well. And lastly, incorporation of patient preferences is not usually included into guidelines. We might have some composite scores, right, for that kind of get to quality of life, but it's not really distilled down to a person level. Additionally, our systems, right, compete this. We don't get reimbursed necessarily or have quality metrics that are necessarily framed around what matters most to that individual. And if we are giving them health that helps them achieve those goals, even though it might not necessarily lower their A1C. So I think it's really important to recognize some of the unintentional harms that following lots of guidelines can cause for older adults. And some of these harms are actually medical harms. For instance, 1 in 3 older adults with multiple comorbidities receive one guideline recommended drug that harms another coexisting condition. But I think the other thing that's really important is thinking about the burden of care and how much time is spent for older adults that have lots of health conditions on their healthcare tasks. So for instance, older adults can spend up to 2 hours or more a day on a healthcare task. That could be checking their blood pressure, checking their sugars, making setting up all the multiple appointments they may or may not have for various tests, right? Maybe just the trips to and from multiple doctors' offices. I know I myself don't have 2 hours a day to spend on healthcare tasks. And I think even if I was maybe retired, right, and not working or didn't have 2 small children, I still don't want to spend 2 hours of my day on healthcare tasks. I would maybe want to spend that on the things that are important to me, like visiting my grandchildren or hobbies that are also important to me, playing cards, doing gardening, going out for walks, all the other things that make a person feel healthy, right, and well-balanced. And lastly, a half a day per healthcare encounter. I mean, it takes a lot. I mean, even with, the advent of more telemedicine, I think it's still important to recognize that there's a lot of time and effort that is spent not only for the actual patient, but just the whole unit, right? The families, the caregivers, and everyone else that's supporting that person to come and do those diagnostic procedures, tests, and office visits. So even though there's all the support, or I should say evidence around how guideline care sometimes is not a one size fits all, I think it's really hard as an individual provider to kind of take a step back and be like, I'm not going to follow the guideline. We kind of talked a little bit about that. One is, I think, just in general, a clinician discomfort, right? We are taught from the very beginning of medical school that evidence-based practice is the way to practice, and that following guidelines is really, drilled in us and is part of our memorization and practicing patterns. And so I think there's a certain bit of a discomfort when you feel like you're going rogue against those guidelines. The other thing too, I think, is that we get conflicting messages. I can share multiple different patients encounters literally within the last 2 weeks, where this kind of, one provider says, this is the way we should do this. And another provider says, no, this is the way we should do this. This is the best evidence-based guideline. No, this is the evidence-based guideline. And so it's really hard to kind of balance all of those different competing opinions for people that you respect in the fields, and try to navigate that path forward with your patient about what matters most to them and based on who they are and their prognosis. And then lastly, I think, again, our healthcare systems for the most part don't necessarily reward us for doing this, right? They reward us for other quality metrics that are easy, kind of quote unquote, to address, like A1C, blood pressures, are they on XYZ medications, but not really person-centered care. However, even though there's all these threats, I think there is, on the flip side, opportunity to this approach. And part of the opportunity is really that art of medicine, it's filtering treatment based on the patient in front of you. And one thing that I have found that's been predominantly helpful is really kind of identifying the trade-offs, and talking to your patient about not only what's important to them, but also what is the burden of the disease and how well do they understand the trade-offs. If they choose this method or if we choose this option, are they okay or are we okay with the trade-offs, right? It helps also identify and clarify the options that are most doable for the patient. Because honestly, like for instance, I prescribe some pretty expensive and difficult medications to treat osteoporosis. But if the patient actually can't do it, and even in the support system around them can't do it, then actually it could be quite harmful for them. And that's a really important thing to address, because if it's actually harmful because they can't do it, then it's actually okay to not offer that to them and offer some other better options. So really it's again about selecting those treatments which provide the individual benefit and less burden. And that really requires a knowledge of the person, who they are, their values, their social situation around them, and their priorities and function. So again, some of the ways to address this is kind of thinking in the big realm of age-friendly care, which I'm sure Dr. Bennett has shared with all of you, and implementing aspects of geriatric care into the framework of the 4Ms. And just to kind of focus on a little bit of what I mean by that is that we're focusing on the what matters most. So really aligning care with the older adult and their goals and cares and preferences within that kind of 4Ms framework. So what does it mean about doing what matters? Really what doing what matters is first stepping back, identifying who the patient is, what are their values, what is a little bit about their culture, and then also translating specific, it's really kind of a nuanced position of kind of identifying the options in front of the patient, identifying what is specific and realistic to some of their healthcare outcome goals. Like if they say, I want to walk better, it's really kind of distilling down, what do you mean by walking better? What is walking better to you? And then talking through what are the options to help get you to that specific goal? And are you willing to participate in physical therapy that might be XYZ times a day over so many weeks to get to that goal? These are the trade-offs between that, to really kind of come down to something that is actionable, realistic, and specific for them. So patient priorities care is a framework and a model for how to have these types of conversations with your patients. It's basically a way of not only sitting down and facilitating the conversation, but then stepping back and aligning healthcare decision-making around that kind of conversation and adjudication about the thing that matters most to that patient. It not only involves healthcare outcomes, but the patient wants to do, but also some of their preferences around healthcare and decision-making in general. It's really a model of care, again, like I said, that elicits what matters most to the person. So it's really moving from Mrs. Jones, you need this treatment because you have diabetes or this disease, to a conversation, a conversation more around knowing your health conditions and overall health and what matters to you and makes you a whole person. I suggest we go this route instead and kind of offering that to the patient as an option. So like I said, patient priorities care is kind of a three-pronged approach. It's first setting the stage, right? By identifying the patient's healthcare priorities, identifying their health outcome goals, and what healthcare tasks they are willing and able to do. And then from that, really kind of helping align and guide the decisions to stop maybe things that are harmful or prevent those from even happening, and to really continue to start the things and the treatment plans that align with those goals and are much more doable and acceptable to the person. And then it's really kind of involving all the other persons in the healthcare model, whether it be specialists or maybe other team members, for instance, like therapists or whomever, with those kind of goals and priorities so that everyone's kind of on the same page with the patient. And sometimes what really helps is to really kind of distill down to that one thing that really matters most. I mean, the thing that is what they can achieve with their health goal. For instance, it might be walking distance so I can return home and independent into my house. And then everyone can kind of rally around that and then kind of help decide, well, are these medications going to be a barrier to that or help support that? Are these kind of like interventions going to help support that person being a better walker so they can get back to their house, or actually they might further delay some of that because XYZ. And like I said, this is really a good model for those people that, really have a shorter life expectancy. The people that, guideline care was not really probably designed for because they were excluded, like as we said, kind of mostly from clinical trials, probably anywhere from, 2 to 5 years worth of life, again, guesstimating, and have several conditions and impaired function already. Just to kind of share, there is some evidence out there in the past several years kind of showing how patient priorities care is helpful. It can reduce unwanted care. It can stop medications, stop test order, which ultimately turns around to healthcare savings, not only for the person, but also for the system. And it also helps patients really feel like they're getting the care that they want and that's focused on their goals. And so they feel less burdened by overall treatment. And clinicians like it for the most part. They feel, I think, that they're more in a partnership with their patient, which is probably many of the reasons why most of us went into healthcare, right? We wanted to not necessarily be dictators over our patients, but we want to work with them, be coaches, right? Help them achieve goals that are meaningful to them and that help their overall health. And it also enhances communication so that patients are, they feel like it's more personable and they feel more knowledgeable as well about their healthcare. So with that, I'll take on any questions. Thank you.